Hey everyone, welcome back to my channel White Coats and Corgis. You probably know me from Instagram or TikTok where I post helpful content for pre-meds who are trying to get through the application process to medical school. In this video, I'm going to be showing you a couple different doctors who are making the least money out of any specialty in medicine. These doctors are going to tell you a little bit about their specialty, how much money they make, and what they do on a day-to-day basis.
So I want to talk a little bit about the pediatric career pathway. So in general, you'll have 4 years of undergraduate school and take all of your pre-medical courses, including biology, general chemistry, organic chemistry, physics, calculus. And then after that, during med school, you'll take all the basic science coursework as well in anatomy, biochem, histology, microbiome, physiology, pathology, and neurobio. And then you'll also go through rotations in different departments. So pediatrics is definitely one of the foundation rotations, but there's also electives within pediatrics that you can take, like you can do a rotation in pediatric emergency or specifically pediatric surgery. So when I was in med school, I also did a couple of electives with pediatric surgery and kind of got to see really cool cases in the OR. But I think whatever specialty you're considering, definitely consider different elective options that you can take to kind of explore the many different areas of each field. And then during pediatric residency, it's kind of a combination of learning the core competencies, so learning evidence-based practice, quality improvements, and all the aspects of patient care and professionalism. And then the clinical training really is also similarly divided into rotations like you would in med school, but you'll do a rotation with the newborn nursery. You'll do a rotation in neonatology in the ICU. The majority of the time will also be in general pediatrics, since that's kind of the core, but you'll work on the wards. And then you'll have an ambulatory clinic. So once a week, you'll have a panel of patients that you see, and it's almost like your continuity clinic where you get to see the same patients, develop a rapport, and really understand what it's like to be a general pediatrician. And then there'll be time rotating through the pediatric emergency department. You'll rotate in the pediatric ICU. You may do an elective in community pediatrics. So I also kind of shadowed and worked with pediatricians in private practice to see what that is like. And then you'll do another rotation in development and behavioral pediatrics. So this is just a little bit about the pediatric subspecialties, and there are many of them. And there are also ones that aren't specifically the track of doing typically a 3-year fellowship after residency. So for example, for pediatric emergency medicine, there are other pathways where you can do adult emergency medicine first and then maybe do 1 year of pediatric emergency fellowship. But in general, it's typically 3 years of pediatric residency, and then after that, doing another 3 years of a pediatric subspecialty fellowship. So this is a survey of satisfaction among early career pediatricians. And it seems like the majority of them are pretty satisfied. Most of them, 87%, find their work personally rewarding. 83% are satisfied with their career as a physician. And then you kind of have a little bit of statistics of their salary, working full time, and what their lifestyle might be like, you know, whether they're married or working as a parent. And so this is, I found useful if you're thinking about a career in pediatrics.
I mentioned my mentor, one of his favorite quotes when people asked him about family medicine is he would say, well, we specialize in the skin and all of its contents. Basically what he was saying is the whole person is what we specialize in. And so I'm going to launch from that idea a little bit. So I had a patient one morning, typical morning. I went into the room. This was an 18-year-old college freshman. I walked in the room and said, good morning. I'm Dr. Bradshaw. Tell me what brings you in today. And he said, well, in the middle of the night, my roommate hit me on the arm, and he proceeded to hit me on the arm and said, dude, go to the doctor. And I thought that was kind of an interesting chief complaint. When we're taking history, we want to write down the reason that the patient came in to see us. And so for him, it was, dude, go to the doctor. And so I've often reflected on that. What do we mean by that? Everyone's heard that phrase, you need to go to the doctor, or we're taking your grandmother to the doctor today, or I went to the doctor today. Most of the time, if that's an undifferentiated problem that hasn't been sorted out yet, that's going to be a primary care doctor, a family doctor. Could be anyone, could be anything. I'm going to touch on that here in the next slide or two. But think about all the reasons you can think of for why people go to the doctor. That's what we do. Now, oftentimes, of course, people will say, I'm taking grandmother to the cardiologist today, of course. And so that's going to the doctor. But the kind of the generic idea of going to the doctor means I don't know what's wrong and I need to find out what's wrong. And that's what family doctors do. We specialize in the whole person, the skin and its contents. We take all comers. One of the phrases that's popular is that we have a specialty of breadth rather than depth. Rather than being deep into one particular organ or particular organ system or particular focused area of practice, we specialize in a very, very broad range of things. And so it is a specialty, but it's a specialty of breadth rather than depth. And that requires a kind of a different kind of person, a different kind of personality. So not everybody's cut out for this sort of field. And we'll talk a little bit about those characteristics as we go. So here are people ask, well, what would a typical day look like for a family doctor? I put these in order of age, but this is not how it would go. You might get any of the next 2 pages worth of things on any given day. You might see a 2-week-old infant who's not nursing well. You might see a 6-month-old baby for a routine well child checkup. You might see a 3-year-old toddler who's got a Lego up his nose. You might see a 5-year-old for preschool physical immunizations, all of those things. You might see a 9-year-old who fell off his bike and mom thinks he has a broken collarbone. Could be a 14-year-old for a sports physical. I did more of those than you can imagine when I was in a small town practice. A 17-year-old for severe acne and ADHD and obesity, a whole lot to talk about. You might see a 25-year-old whose menstrual cycle is irregular, 40 down his leg. A 50-year-old with new onset headaches is a cancer doctor. A 60-year-old with high blood pressure, high cholesterol, stress, who's a smoker and is having some chest pain. Maybe a 70-year-old with new onset weakness and hand tremors. An 80-year-old who's dizzy. That was always the bane of my existence when I was in private practice, because that could be anything. And boy, that's when you talk about an undifferentiated problem, dizziness is about as undifferentiated as it gets. Could be a 90-year-old who has cancer and needs to be put on hospice. So there's 2 pages of the kinds of things family doctors might do in a, quote, typical day. And again, not in order, not in clumps. You don't see all your 60-year-olds on the same day. You could go from the 60-year-old to the infant, to the toddler, back to the menstrual problem. And that could be the flow of a day. And oftentimes, at the beginning of the day, you don't know what that's going to be, which makes it fun, exciting, a lot of variation, but can also introduce a little stress if that kind of day is not your natural way of functioning.
Right.
So I like to joke that, there's one of the cool things about medicine is all the technology, and there really is some amazing stuff that people can use and procedures people can have and technology we have to offer. But for us, the basic tools of the trade are right here. You need a good pen, a good stethoscope, and an otoscope, and you can probably carry out much of your day with those three things.
So this may be a little bit redundant because I did put in some of what we were talking about just to review. I think another feature of neurology, just to give an introduction, I was influenced, as a lot of neurology residents are, by the works of Oliver Sacks. So he is a neurologist who probably wrote at least 10 books or so on what his patient experiences were like. And I myself never heard him speak, but I believe he did travel to a lot of institutions as well. It was quite popular, again, years ago, about how fascinating neurology is. And I think what stood out to me with these patients are, of all the areas of medicine, to have the involvement of the brain, of ability to speak or ability to move, being lost, seems so much more striking than any other organ system. So trying to put yourself in the footsteps of what these patients are going through, someone who's had a stroke or someone who's been diagnosed with a brain tumor, seems so much more moving to me than some of the other areas of medicine. And reading his works is something that I would totally recommend for anybody who is contemplating the field of neurology. Just to review, this is what I talked about before with the training. So again, it's a bit more complicated than the average medical training, in that there is the option of doing the child neurology program. And with that, not only is it confusing that you're matching early, but it's also hard to find, at least when I was applying, find a pediatrics program that will let you leave a year earlier than the average pediatrics residency. Most pediatrics residencies, again, are 3 years, and then you do 3 years of subspecialty training in like pediatric GI or pediatric cardiology, pediatric pulm. That's a lot of time in one's life to be training and be, a resident and a fellow. So I think, again, it's something that is difficult for a lot of medical students to commit to, whereas some other specialties are much shorter in terms of their training, and you can go out and practice as an attending really much quicker. So just something to keep in mind, that child neurology, it is a 5-year program. Adult neurology is 1 year of internship and 3 years after that of general neurology. And if you do an adult neurology training, you get 3 months of exposure to child neurology. If you do the child neurology, you get at least 1 year of adult neurology. And then I did some electives, again, in adult neurology as well. So I felt I had a lot more exposure, that I could take care of adults. I am certified to care for adults. The boards are neurology with special qualification in child neurology, so I can see both. But most neurologists stick to either adults or pediatrics. Again, I think that's what makes child neurology a bit unique. Depending on the specialty training, some child neurologists will see patients up until a certain age. Like if they do epilepsy training, which is what I did, sometimes they'll follow the epilepsy patients into younger adulthood, or sometimes even older, again, depending on what part of the country you're in and what the need is. So after you do all that time of 5 years or 6 years of neurology, a lot of others will do subspecialty training, where they'll do a fellowship in stroke, or a fellowship in EEG, or a fellowship in Parkinson's, movement disorders. Again, it's a lot of time. So you really have to know that this is what you want to do. This is what keeps you up at night. This is what excites you more so than, any other field of medicine. It can get quite confusing and intimidating early on, but it's so worth it. During the training, there's nowhere else I wanted to be. So my day-to-day life, again, I'm atypical compared to many others in medicine in that so many of us choose one concentration. We might be hospitalists and only inpatient, or we might only see patients in private practice and again, like a niche like Parkinson's or such, depending on what part of the country. And I think it's very variable. I think it's important to recognize you're going to go where the need is. So I practice in a suburban setting. So I'm outside all of the academic institutions where they have a lot of access to subspecialists. Where I practice, there's more of a need, I feel, for adult neurology because the patient population is such that a lot of the pediatric cases can get over to one of the bigger tertiary care referral centers, or where I'm in the Northeast. So we have CHOP nearby, we have Children's Hospital of Boston nearby, we have multiple hospitals in the city nearby. So most of the pediatric patients I see are relatively healthy, which is really nice. And again, I think that that goes to show that there's a wide variety of what you can practice within child neurology. I think, and the same with adult neurology. Some medical students or residents, they don't look forward to seeing really sick patients. It can be quite devastating to work with patients who are near death or have severe debilitating illnesses. But there's an option here. Again, in neurology, nowadays, we're seeing patients of all different subtypes. So I think, again, where I practice, most of the outpatients that I see are headaches, epilepsy, or even not even epilepsy, sometimes a single seizure that hasn't yet met the criteria for epilepsy, head injuries. And more common than anything else where I practice is actually neurobehavioral concerns, such as evaluations for attention deficit, and sometimes even other behavioral concerns like anxiety or maybe irritability or depression. And again, going through my training, I was in more of an inpatient setting. I really wasn't overly exposed to disorders like attention deficit. But in the community setting, this is bread and butter. Depending on what part of the country you're in, disorders like attention deficit can be managed by different providers. So sometimes it's going to be general pediatrics, sometimes it's going to be child psychiatry. But again, I think it's all about access. So particularly where I practice, the pediatricians will send their attention deficit patients to child neurology. So that's a lot of what I do in my day-to-day life when I'm working as an outpatient. When I work as an inpatient, I do something very different. I mainly help with the adult neurology patients. So again, in my community, we have a lot of elderly patients who suffer from stroke or suffer from other behavioral concerns. Altered mental status is probably one of the most common reasons why we would get consulted in the hospital. So that's something that I help with. I work in a practice of, I believe, 16 or 17 other neurologists. And so I'm lucky to have a lot of backup from the many adult neurologists in talking about cases and going where I'm needed. But one of the other ways that I help in the inpatient setting is through epilepsy monitoring unit interpretation. So I did a one-year fellowship in epilepsy following my child neurology studies. And that's been so useful because probably the most common procedure that we do as neurologists is EEG interpretation. And that, again, is useful both in adult neurology for patients who come in whose thinking is not where it should be, or child neurology in cases, again, of seizure disorders or other, again, changes in behavior, sometimes even abnormal sleep. We'll do EEG monitoring to look at the sleep and see if there's something else going on. So I do a lot of epilepsy monitoring unit interpretation, and I'll talk a little bit more about that as I go along.
The first thing before we get into any cases, this is just a diagram from the American College of Physicians that talks about the pathways within internal medicine. And I think this is a good representation of all the different career pathways that you can have within internal medicine. So to start out, internal medicine training is 3 years, and that's a general internal medicine residency. And so once you complete that, you have the option of going into primary care and being someone's PCP. You have the option of specifically focusing on hospital medicine and being a hospitalist, or you can have some combined version of the two, where you do some inpatient, you do some outpatient, but you're a general internist. You're taking care of anywhere from like all the patients in the hospital, because everyone who's non-surgical is basically admitted to a medicine service. Or you are taking care of, a variety of 18 to 93-year-olds. So there's a lot of opportunity in the general internal medicine space. But if you choose to subspecialize, which a lot of people do, you have all of these. Can you see my mouse? Okay. You have all of these career pathways open to you as well. And so yes, the basic internal medicine training is 3 years, and you come out of that as a full-fledged physician, able to practice. But for a lot of people, the training ends up being 4 to 7 years, if not more. You can see that there's a lot more even within cardiology, and so the training can be long. But these are the different options that you can have, and I think that the great thing about this is, internal medicine can cater from any type of personality. So you can go into internal medicine training and realize you really, really, really like procedures, and you really, really like sort of the things about surgery that you thought you didn't like maybe going in. And then if you want to do that, you can become an interventional cardiologist, or you can become a gastroenterologist, and you basically spend your entire day doing procedures. If you decide, I really like being a master diagnostician instead, you can become a rheumatologist, you can become an ID physician. So there's something for everybody, I think. And there's, again, no two careers are alike, and there's infinite options open to you if you go into internal medicine. So I think this was the great thing about where I did residency. And in general, like, you're exposed to all of these different things within internal medicine. Like, as a medicine resident, you will admit your acute leukemia patient, but you'll also admit your classic ST elevation MI STEMI patient. And so you'll see a lot of different things, and you'll see what kind of medicine you're most drawn to and what kind of pace of life you're most drawn to. But the other thing is, especially a lot of larger academic centers have subspecialty services. So where I did residency, we had like an ID service, we had a pulmonary service, we had a liver service, we had a cardiology service. And so we spend time rotating through all of those different specialties. We spend at least 2 weeks on each specialty. And you're learning from a cardiologist, you're learning from a liver specialist, you're learning from attendings who have chosen to do fellowship in that field. And so that gives you a good sense of the inpatient side of it. And then you always have the opportunity to go to outpatient clinic. And a lot of internal medicine, which is not true of residency, like 75% of internal medicine is actually practiced in the outpatient setting. So that's another really good way to see what kinds of pathophysiologies and pathologies and kinds of patients you're most interested in. So the point of your internal medicine training is, yes, to give you a good foundation for general internal medicine, but also to help you see all of these different things and decide if any of them are right for you and which of them it would be.